Shall I start, sir? Yeah. Good morning, everybody. It's the quantity of the audience rarely matters. It is the quality of the audience that is what matters. I remember an incident. Once I was invited to Gangtok for a demonstration, and he said, my close friend who was working in Gangtok said, I'm organizing a wonderful event. There will be 300 plus delegates. I will arrange all your, logistics, flight, ticket, accommodation, everything. I was excited. So when the conference was nearby, he said, the sponsors have refused. यार टिकट का पैसे नहीं मिल रहा, क्या करो? चलो भैया मैं खरीद लेता हूँ टिकट. बाद में बोला कि सर होटल का भी कुछ नहीं हो रहा है, तेरा घर में कहीं पे जगह है क्या? चलो, if you have good number of delegates, that's good enough. At least that will motivate me to come. So I went and stayed with him. Then when I ultimately reached there were only about 7 people. But I'll tell you, we did wonderful workshop there. And after coming back, I'll tell you, after 6 months, one of the delegate called me up and said, sir, आपने जो demonstrate किया था, I did that case today, went off wonderfully, very well. And that is the satisfaction which I got that day. And really that is touchy. So that is what is important. Okay, see, this is actually 8 hours lecture. I do this extensive 8 hours lecture. I wrapped it up for 45 minutes. And I dedicate this to my alma maters, that is JJ Medical College, Davangere, and PGH Chandigarh, mainly the PGH Chandigarh, where we got an opportunity to learn radiology of the temporal bone. Every Wednesday afternoon, we used to have a radiology combined department of ENT and radiology combined classes, where all the important radiological investigations that were done last 1 week, we were supposed to present, and they used to discuss, show us. That's how I get to learn that. Yeah. Why radiology? We have the radiologists. Should we depend on this thing? But I will tell you, if you can read the radiological film yourselves, that mainly the HRCT temporal bone, you will first to start with, you will master the anatomy, okay? And also you will get the optimum diagnosis, okay? Radiologists will see only from radiological perspective, where you as an ENT surgeon, you will not only read it from ENT perspective, also radiological perspectives, you get a right diagnosis. And also surgical planning, that's a radiology will provide a roadmap kind of this thing for surgical planning. And also it will, when you understand the extent of the disease, pathology, everything better, and anatomy better, you will minimize the complications and maximize the results. It is your results which speaks for you. They are the best advocates for your career. So this is why it is important. Can anybody tell me there are how many surgeries in otology? Because this emphasizes why we should learn radiology of the, learn HRCT temporal bone. Can anybody tell me how many surgeries there? I remember this Akbar Birbal, there are how many crows in the city. Same type. I'll tell you, can anybody give a rough guess how many surgeries in otology? One number, sir. 100. That means you are yet to explore the remaining surgeries. I think in remaining career we will do, there are 350 surgeries in otology. I'll tell you, if you want to do, otology is a very vast field. In Western world, otology, they do fellowship course in otology, and they do focused work from external ear to internal ear. There are more than 350 surgeries, and as we speak, they're growing every day. Only thing is that when you master radiology, you start exploring, new entities, new things, should start doing that. That's why I emphasize. And which view should I learn? There is no single view that, that will give you comprehensive information. You have to learn to read all the views, sagittofmaxial, coronal and sagittal view. And also other 10 different views are there. Like postal view, this is very good for, this is the superior semicircular canal. This is to assess the dehiscence of the superior semicircular canal. This is good. And sagittal oblique reconstruction, this is good for to study mainly the this thing enlarged aqueduct, okay? Endolymphatic sac and endolymphatic aqueduct is a very good view. And molar tooth view, this is mainly for the ossicles. If there is following trauma, ossicular dislocation, disarticulation is there, or there is ossicular destruction is there in disease, that is important. And also there are other reconstruction views where you can see entire length of the cochlea. This is important for cochlear implant surgeons to assess the length of the cochlear duct, okay? So that what's the length of the electrode they can use. And also now there are 3D reconstructions they do. They give entire the labyrinth, you will get the view. So you have to master all this thing, all the views, and also you can see individual semicircular canals, superior, posterior, and lateral semicircular canal, individual semicircular canals they can show. And routinely, how do they take CT scans? Is they usually take parallel to the floor, that is meatal plane from lateral canthus of the eye to extraordinary canal. Then what they do now, the recent CT scans, they just do the scan in axial planes. Okay, then they do 3D reconstruction using computer algorithms. That's how they're doing. Now they don't put the patients into different positions, and always try to have one of these DICOM softwares. If you are a Mac user, use this Horus, or if you're using a Windows, that Radiant software is excellent, where you can study the CT films in continuity. Yesterday, Dr. Sethi, he emphasized this, where we can study the pathology of like entire, not only the temporal bone, you can also study the PNS in relation to it, and this is very important. And when you start studying the axial sections, you should develop one specific system of reading. So axial sections are taken from superior to inferior. You read the sections at superior to inferior. Usually we take thickness of 0.6 millimeter and at a distance of 1 millimeter, but now that is also being reduced. Every 0.6 mm cuts are being taken. So when you study the CT scans, axial sections go from superior to inferior. You understand better. And each film, how you should study from anterior to posterior and from lateral to medial. That way you will cover all the subjects. When you are studying the coronal sections again you go from anterior to posterior. Okay, that will give you a better this thing. And when the coronal, each frame you study from lateral to medial and superior to inferior. That way you will not miss anything. And sagittal sections, you go from lateral to medial each section, and also each individual section you go from anterior to posterior and superior to inferior. If you develop this way, you will learn better. And each frame you have to do 3 passes, like we do in a diagnostic nasal endoscopy. We do 3 passes. In the first pass you study the normal anatomy. In the second pass, anatomical variations, if any are there, you try to study them. And in the third pass, pathology, what pathology is there in relation to anatomy, you should study. Okay, and some principles I'm going to tell you. This will help you to master the HRCT temporal bone very well. First is horizontal axis of the temporal bone. See, temporal bone, we have learned that it is like a pyramidal shape, with mastoid cortex being the base of the pyramid, and apex is anteriorly, medially, and inferiorly. As you can see here, the apex of the temporal bone pyramid, that is directed towards the sphenoid bone. Okay, and also if you see from lateral to medial in a coronal section, it is directed inferiorly. Okay, there is a slope is there. That because of the slope, when we study axial sections, first what we get is these air cells first laterally. Okay, so that is what we need to focus, and in one glance you should be able to assess the pneumatization of the temporal bone, starting from almost no pneumatizations to maximum pneumatization here, hyper-pneumatized temporal bone, where the pneumatized air cells go up to the petrous apex. Okay, that we should be able to appreciate. And second principle is tubes and circles. Okay, the structures, the temporal bone has various tubular structures. Okay, facial nerve is a tubular structure. Internal carotid artery is a tubular structure. Extraordinary canal is a tubular structure. And internal auditory meatus, internal auditory canal is a tubular structure. Okay. So what happens is, if you are studying a axial section, whatever structure is there, tubular structure, that looks like a tube. So this is internal carotid artery, it looks like a tube. This is extraordinary canal, this looks like a tube. Whereas if you study in this section, sagittal section, the extraordinary canal looks like a circle. That means this is taken perpendicular to the external auditory canal. Okay, this section, that sagittal section. So you should have this orientation, tubes and circles, and that will make you very help. For example, when you go from superior to inferior on a axial section, the top portion of the superior semicircular canal, it appears like a tube, isn't it? Whereas if you go further down, the arch of the individual arches of the superior semicircular canal, they look like circles, because now they are perpendicular to the axial plane. So this is the orientation we should have. Same thing about the facial nerve also. If you want to study, this is the cochlea, and here is the vestibule, and this is the facial horizontal part of the facial nerve. So you can see the tubular structure which is parallel to the axial plane, and you will be able to study the facial nerve dehiscence better. Okay, and on coronal section, whereas this section is perpendicular to the facial nerve. This will look like a tube. This is a dehiscence of the facial nerve. So this is the orientation we should have, and also the superior semicircular dehiscence, which is seen better in postcal view. Coronal section also here. This is perpendicular to the superior semicircular. You can appreciate that as a tube here. This is a dehiscent superior semicircular, where you can see superior semicircular open to the middle cranial fossa here. Okay. The other third principle you need to remember is the planes of the internal artery meatus and external artery meatus. If you see, both are parallel to each other, isn't it? Internal artery meatus is parallel to the external artery meatus. But whereas here, if you observe, the floor of the internal artery canal is at the same plane as the roof of the external artery canal. Okay, this is a transition point I call. Lot of important structures are present here. If you study, see, this is the vestibule, and here is the oval window with the stapes foot plate. The stapes will be here. Here, if you see, the ossicles are here. The scutum, which is an important structure, mainly if you want to study the cholesteatoma CT scans. This is nothing but lateral aortic wall. Okay, the scutum is there. And when you study these sections, look at this external artery canal both sides. When you go systematically, here you can see there is a soft tissue occluding the external artery canal. This is atresia of the external artery canal. This is soft atresia of the external artery canal, where there is the soft tissue plug is there. Okay, here another soft tissue atresia of the external artery canal. This is soft tissue atresia of the external artery canal bilateral. You can see it is totally occluded. And we also have bony atresia here. Compare the both sides. One of the way to learn anatomy and anatomical variations better is compare the two sides. Okay. And if you see here, external artery canal is very well formed this side here, whereas it is not there at all. There is bony atresia is there. And if you see other areas also, we should be able to study the ossicles here, well formed ossicles, ill formed ossicles, not well formed ossicles here. That you should be able to appreciate. Compare the both side external artery canal. This is for atresia of the external artery canal. Again, another nice external artery canal. Here it is atresia external artery canal. Okay, we should study like this. This is another mainly there is only this wall atresia is there. That we should be able to appreciate. And coming to the other pathologies in the external artery canal, keratosis obturans. How to identify keratosis obturans when we have confusion whether it is external artery canal cholesteatoma or obturans? So what do we do is, if you look at the CT scans, usually there is a expansion of the external artery canal will be there compared to the opposite side, but there won't be any bony erosion, and mid-layer and tympanic membrane will be absolutely normal. That you should be able to appreciate. Okay. And what happens in the malignant otitis externa? There is a lot of soft tissue edema and also little bony erosive points you will be able to appreciate mainly. And you can also see the bone erosions in the other parts of the skull bone also. Okay, and also with intracranial extension, you will be able to see soft tissue this thing. The first sign of external artery canal cholesteatoma is on a CT scan, the subtemporal triangle, we say subtemporal triangle, that is below the external artery canal, that all that will become edematous. Okay. Coming to the exostosis is nothing but bony swellings in the external artery canal. They are broad-based swellings which appear either anterior or posterior wall of the external artery canal. Okay. And osteoma, whether they are sessile, we have a small attachment. Okay. We should be able to differentiate that also. Okay. This is exostosis, and this is osteoma, which is pedunculated or sessile it is. Okay. Whereas this is broad-based. And sometimes patient present to us with trauma, mainly trauma to the chin, and when they open and close the mouth, there will be severe pain and also tenderness over the temporomandibular joint. We should be able to appreciate the fractures of the tympanic bone, okay, anterior wall of the external artery canal. And acute mastocytitis, if you look at the air cells, how it appears is, that is, you will see fluid or kind of low density opacity in the mastoid cell system. This is normal. Here you can see the mid-layer and mastoid. You can see the fluid in the soft tissue density. You will be able to see. This is the same picture you will get on serous otitis media also. Serous otitis media also. You can see all kind of the cells become a cloudy appearance of the cells will be there. That normal cell architecture that is obliterated by this cloudiness. Okay. And acute coalescent mastocytitis, what happens is, from cloudiness to it start dissolving the air cells. Because of the hyperemic decalcification, this starts dissolving the air cells, and slowly, all the air cells become dissolved, and the discharge or abscess formation, granulation formation can occur, and slowly there may be erosion of the dural plate and sinus plate. Okay. And chronic otitis media, what happens is, mainly it leads to, because of the repeated infections, it will lead to the sclerosis of the temporal bone, okay? Sclerosis of all the hair cells, and there may be in the mid-layer and in the mastoid antrum, there may be soft tissue density in chronic otomastoiditis. This is non-cholesteatomatous, okay? Okay, and in complicated otomastoiditis, what you will see is erosion of the dural plate, either anterior or posterior. Here it is anterior erosion is there, the infection spreading to the middle cranial fossa. That we should be able to understand. And coming to the extranatory canal, this one, we need to differentiate this from keratosis obturans. Here, instead of expansion of the extranatory canal, what happens is erosion of the walls of the extranatory canal will be there, and you will see small sequestrum or bony fragments within the soft tissue density, within the cholesteatoma here, that we should be able to appreciate. And also there will be erosion of the bone will be there, okay, that we need to appreciate that. This is another case of extranatory canal cholesteatoma. You can see here, this in the extranatory canal, okay, there is bony erosion. You can see it can erode towards mainly posterior, inferiorly it will start eroding. That we should be able to appreciate. So here another extranatory canal cholesteatoma, so it started eroding into the mastoid cell system, okay, but it's confining to the extranatory canal, and there is no expansion of the extranatory canal will be there, okay. Next, other fourth important point you need to remember is mid-layer divisions. How mid-layer is divided is into three parts: epitympanum, mesotympanum, hypotympanum. How we divide is arbitrarily a line passing through the roof of the extranatory canal and another line passing through the floor of the extranatory canal. Whatever above this first line is epitympanum, below this second line is hypotympanum, in between is the mesotympanum. But on a CT scan axial, when we are studying, how do we identify where exactly we are, whether epitympanum, mesotympanum, hypotympanum? See, if you are in epitympanum, you will see the ossicles here. If ossicle has a ice cone appearance, typical, okay, that means you are in epitympanum. But if you are in a mesotympanum, these ossicles appear like a two dots or two lines, okay. Remember this, dots and lines, okay, two dots. This is nothing but handle of the malleus and long process of the incus. They looks like dots and lines. And if you don't see anything, you just see air, empty, that means you are in hypotympanum. This is, at a glance, the moment you see, you should be able to understand you are in epiglottis, mesotympanum, epitympanum or mesotympanum or hypotympanum. Coming to the cholesteatoma, the congenital acquired cholesteatoma classification we know, and acquired again it can be primary or secondary. And we also sometimes classify as past tense cholesteatoma, that is mainly posterior mesotympanic cholesteatoma, and past flaccida cholesteatoma, that is arterioepitympanic and postepitympanic cholesteatoma. And this is past tense cholesteatoma, mainly appears over the promontory in the mid-layer, okay. So when we study the first flaccida cholesteatoma, that is our point of focus. We need to study these points, mainly the bony ossicles, stapes foot plate, this we should be able to study, and sinus tympani, because a lot of cholesteatoma likely to remain here, and many surgeons are afraid to dissect the cholesteatoma for fear of causing disarticulation of the stapes foot plate. And sinus tympani we should study because we need to exercise complete cholesteatoma, mastoid cell system, tegment tympani, to look for any class of any erosions, lateral semsa canal, facial nerve canal, and sigmoid plate inner ear. And these are best studied on a coronal section. I showed you, that is, this is the scutum. The first sign of cholesteatoma, first flaccida cholesteatoma, is erosion of the scutum, followed by the erosion of the ossicles. Then it can extend here. You can see this is in the mainly the cholesteatoma is the sinus tympani and the stapes foot plate area, also in the mid-layer. So one differentiating point for cholesteatoma from many other soft lesions is this is non-dependent, means you see you mainly see the pathology in the attic. It is not following the gravity, it's not falling down. Okay, if there is a fluid or something, you will be able to, that will be in the flow. Okay, whereas here it is non-dependent soft tissue density mass, that is cholesteatoma. Okay, yeah, this is, you can study better the scutum and the ossicles here. This is a dependent soft tissue density mass. And here you can see this soft tissue density mass entire the Prusak space. These are the ossicles. The malleus mainly, and this is the lateral aortic wall, and it is in the Prusak space, okay. And there may be ossicles eroded or displaced, okay. And one characteristic you can see here, where you are at the epitympanum, together mastoid antrum, epitympanum, they give a kind of hourglass appearance, okay. That also you should remember, where in continuity the cholesteatoma grows back to the mastoid antrum. The ossicles will be displaced or destroyed because of the cholesteatoma. and we should be able to, as you can see here, erosion of the ossicles, we should be able to appreciate. Depending on this, you can see whether cholesteatoma is going to medial to ossicles, whether you will have to perform a ossiculoplasty at the end of your cholesteatoma surgery. And extending into the mastoid cholesteatoma is going to the mastoid cell system, you will be able to appreciate where all this mastoid cholesteatoma may be involving. And erosion of the facial canal, I showed you this is the horizontal part of the facial canal, this is cochlea, this is vestibule, and here just below the lateral semicircular canal, the horizontal part of the semicircular canal, horizontal part of the facial nerve you can appreciate, and there may be erosion of the bony canal. So this is, if you understand this, if you study this, okay, you don't have to be surprised during surgery. You can go prepared, very well prepared, and avoid injury to the facial canal, okay. And erosion of the lateral semicircular canal, this is the lateral semicircular canal. This is typical signet ring appearance we call for the lateral semicircular canal, okay, where the diamond of the signet ring is the vestibule, remaining lateral semicircular canal becomes the ring part. And here you can see erosion of the lateral semicircular canal, and this is the lateral semicircular canal, okay, and this is superior semicircular canal, lateral semicircular canal, this is vestibule, this is cochlea, okay. This all together gives a kind of a swan appearance. I will come to that little later, okay. And erosion of the sigmoid plate here, you can see we should study this along with lateral semicircular canal, sigmoid plate erosion also there, and erosion of the tegmen plate also may be there here, tegmen plate erosion we should study, so we should go prepared, okay. And mastoid cortex erosion can occur, all the air cells may get eroded, that we should study what is the extent of the cavity, we know that, and also if any intracranial complication like this is cerebellar abscess is there, and also lateral sinus thrombosis, we should be able to study this. And also when in confusion, mainly in revision cases, is there a recurrent cholesteatoma, so what we take is DWMRI, but a learned otologist who examines the ear with a microscope, that doesn't have to depend on DWMRI, but some centers they do. Congenital cholesteatoma, the origin is uncertain, usually involves anterior superior quadrant and spreads posterior superior mastoid area, and usually presents, in the average presenting age is around 4.5 years, and male is to female about 3:1, and the incidence is only about 0.2 in a lakh patients, okay. So what are the characteristic features for congenital cholesteatoma is normal tympanic membrane, there is white mass medial to the tympanic membrane, no history of otorrhea, and no otological procedures. However, there may be history of otitis media earlier. That we need not take into consideration. This will appear like a mass behind the tympanic membrane. So what happens here is usually in the congenital cholesteatoma, usually lateral aortic wall is that scutum, what we call, that erosion will not be there, and you will see the cholesteatoma mass, again non-dependent mass, soft tissue density mass, non-enhancing soft tissue density mass, medial to the malleus, medial to the ossicles mainly. Okay, the other fifth point you need to remember while studying the temporal bone, that is the vestibule. This is called heart of the temporal bone. It is usually in the center. Whichever direction you study, you will find the vestibule in the center. Okay, so that's why it's called heart. Okay, that is. And if you see another, I say heart or CVS, if you go anterior posteriorly, what you first see is the cochlea, and next the vestibule, next the semicircular canal. That's why I say I keep this mnemonic as CVS. Okay, and here this is the signet ring appearance of the vestibule and the lateral semicircular canal, and this is the vestibule in the center. Here vestibule again in the center. So you have to remember this is a central structure. That sixth important point you remember is this is called the vestibulocochlear line. You draw a line parallel to the internal artery canal. Okay, between the internal artery canal, an imaginary line. Whatever structure is anterior to it is the cochlea. Okay, anterior and medial. Whatever posterior lateral is the vestibule. Okay, this is another very important point. And when we want to study cochleovestibular anomalies, vestibulocochlear anomalies, this becomes very handy. If you are a cochlear implant surgeon, this becomes very important. Usually when it is normal, we see cochlea and vestibule distinctly, like I showed in the picture. In labyrinthine aplasia, either structure are not there. Even it is only a rudimentary otocyst, you just see a small dot. And cochlear aplasia, you will see the vestibule, but there is no cochlea here. Common cavity, both are joined together. In cochlear hypoplasia, normal vestibule, whereas the cochlea is very small. Okay, and in IP, that is partition of the cochlea, where 2/3 in canal is not there, lesser canal is there, 1.5 canal is there, that you will be able to appreciate. I'll quickly pass through this thing, and this is a cochleovestibular hypoplasia. There is no vestibule and cochlea at all, and the complete labyrinthine aplasia, there is no internal ear organ at all, but there's a middle ear is there, but no internal organ is not formed, and completely that is further confirmed by a MRI. You will not find the nerves and other structures here, no cochlea and vestibule at all. Rudimentary otocyst, entire middle ear is there, but the internal ear is looks like a small cystic cavity. This is rudimentary otocyst, we should be able to appreciate. And cochlear aplasia, you see there is the signaturing appearance of the vestibule, but there is no cochlea. Okay, the internal aortic canal is there, but there is no cochlea at all. With that, we should be able to appreciate common cavity. Both cochlea and vestibule together looks like a single common cavity that we should be able to appreciate. Cochlear hypoplasia, you can see, again you draw the line, that imaginary line. Vestibule looks okay, but cochlea is very small. Cochlea is very small. Cochlea is very small. Okay, cochlea is very small. Okay, that we should be able to appreciate. Incomplete partition, there may be one turn, two turn, like what we say, Mondini deformity, all those deformities can be there. And sometimes partition 3 we say, that is Christmas tree appearance of the cochlea. If it is there, this is type 3 incomplete partition. And sometimes there may be vestibular aqueduct. Okay, vestibular aqueduct enlargement may be there. This is important to know before we do cochlear implantation. Other tip 6 is identifying. Remember, cochlea is always anterior, inferior, and medial to the vestibule. This is another identifier you should remember. Okay, cochlea is always anterior, medial, and inferior to the vestibule. This we need to identify. Other important point, tip 7 to remember is anterior structures. I keep this mnemonic called Mecca. So what happens is anterior structures, mainly what we see the malleus or head of the malleus. Okay, then we see epitympanum also is lying to the anterior. Then we see cochlea also anterior, and because the carotid artery, internal carotid artery is also anterior, and audit tube is anterior. If you remember that these are the anterior structures, then it becomes easy. Facial now, this is one structure we need to study in detail. Okay, and I love this thing, the mnemonic, how to remember the different parts of the facial nerve. I love going to masti parties like yesterday night one. It was real masti party yesterday night. So the I stands for intracranial, labyrinthine part, geniculate ganglion, tympanic part, mastoid, and parotid part. That we should be able to identify. This is a temporal bone dissection to show the different parts of the facial nerve. Okay, this is the facial nerve. This is the intracranial part. This is intracanaliculaar part. This is the labyrinthine part. This is the first genu. This is the horizontal part. Second genu. This is the vertical part, and this is stylomastoid foramen where it is exiting. And this is the intraparotid part. This is complete dissection has been done. This is the sigmoid sinus. This is jugular bulb. Anteriorly we have the internal carotid artery, and cochlea is here. Eustachian tube is here. Okay. And the facial nerve and axial sections, how to identify. If you look at here in the intra-aortic canal, we can't differentiate the facial nerve from remaining structures on a CT scan. But the moment here, this is the transverse crest. You can see here, this is the cochlea. Facial nerve is going here. This is the labyrinthine part, and this is the first genu, and anteriorly you can see the GSPN nerve going anteriorly, and this is the horizontal part of the facial nerve medial to the ossicles. You should be able to appreciate. Okay, other identifying point is here you see the vestibule like a signaturing appearance. Okay, so next this thing you can see, this is horizontal part of the facial nerve. As you come here, the horizontal part of the facial nerve, and this is the second genu of the facial nerve. Okay, second genu, and then the vertical part of the facial nerve. That in a continuity we can study if you are using a DICOM image. And on a coronal section, how to identify facial nerve. And you can see this is facial nerve, this is the labyrinthine part, this is the horizontal crest. Okay, horizontal or transverse crest, and this is the labyrinthine part, and this is the first genu of the facial nerve. Okay, and this is the first genu of the facial nerve, and also horizontal part of the facial nerve. And here this is the cochlea, vestibule, the superior semsecanal, lateral semsecanal, and lateral semsecanal just below the arch of the lateral semsecanal is the facial nerve. That we should be able to identify. And the vertical part of the facial nerve, remember this lies more or less at the same level where the arch of the posterior semsecanal is there. Two tubular structures in on a coronal section that we should be able to identify. So the facial nerve genua, however, where are they located, we should remember. So this is the lateral semsecanal, superior semsecanal, this is the cochlea. You can see the cochlea turns. The first genu of the facial nerve which runs under the lateral semsecanal here. Okay, here. Okay, this is anterior and superior to the cochlea. Whereas the second genu is, this is vestibule is here. It is lateral. Okay, lateral to the vestibule. Okay, so this is cochlea that we can identify easily. The first genu is usually it is lateral to the cochlea, whereas this is vestibule, cochlea, and the second, the vertical part, second gene of the facial now is lateral to the and little posterior, lateral and posterior to the vestibule. Here it is lateral and anterior to the cochlea, the first gene that we should be able to identify. And one more thing, you should also be able to identify, that is, I told you one more, that is plane, that is the vertical part of the facial nerve where it is exiting at the stellomasted foramen. This is more or less at the same level as posterior semicectional and a coronal section that you can study. This is the posterior semicectional and this is the vertical part of the facial nerve. They more or less at the same level. That with that you will be able to identify. The most difficult, what has made the anatomy of the temporal bone so complicated is, one is the facial nerve anatomy, the other thing is semicircular canals. Understanding this is very important. First we need to identify and understand the orientation of the semicircular canals. First I told you the orientation of the temporal bone, it's a pyramidal shape. It is directed anteriorly and medially and inferiorly. So this is the posterior surface of the temporal bone or horizontal axis of the temporal bone, remember, okay? So when we go from superior to inferior, you see the superior semicircular canal, the orientation of the superior semicircular canal is perpendicular to the horizontal axis of the temporal bone, okay? Keep this in mind. The superior semicircular canal orientation is perpendicular to the horizontal axis of the temporal bone, okay? Whereas this is posterior semicircular canal, this is parallel to the horizontal axis of the temporal bone. So when we want to study, first you identify the horizontal axis of the temporal bone, then in relation to that if you study it becomes easy. Whereas the third, in between the lateral semicircular canal, which is in between superior and inferior, superior and posterior semicircular canals, usually it is parallel to the mastoid cortex, okay? If we remember this orientation, it becomes easy. And semicircular canal, again you can see here, the vestibule is in the center, this is vertically oriented. This is superior semicircular canal, whereas this is the posterior semicircular canal. Lateral semicircular canal, here it is horizontally oriented, and this is lateral semicircular canal. It is not perfectly horizontal, little 15-degree angle will be there. These are the two arches of the lateral semicircular canal and a sagittal section, okay? This is another picture showing, this is sagittal section showing the, superior semicircular canal, posterior semicircular canal, and this is lateral semicircular canal, okay? Two arches of the lateral semicircular canal. And I told you, where you see the posterior semicircular canal at the same time, at the same level, you will be able to see the facial nerve also, okay? And a sagittal section with the stellomasted foramen. So this is picture to show, to make that even more easy for you to remember. The green lines are the horizontal axis of the temporal bone. You can see the superior semicircular canal arch is perpendicular to the horizontal axis of the temporal bone, whereas here this is the posterior semicircular canal and this is the vestibular aqueduct. Both the structures, they are parallel to the horizontal axis of the temporal bone. One more thing, if you are able to see the internal artery meatus, and here internal artery meatus runs, perpendicular to the horizontal axis of the temporal bone. So superior semicircular canal will be parallel to the internal artery meatus, whereas here the posterior semicircular canal will be perpendicular to the internal artery meatus. The other pointer you can remember. Whereas the lateral semicircular canal, more or less, it is parallel to the mastoid cortex here. That is the identifier I keep for myself. And one more thing you need to remember, when you go from lateral to medial, they are not in the same plane, all the three semicircular canals. They are kind of staggering position. Each semicircular canal is 2 mm medial to the other. When we go, as a surgeon, when we go laterally, first structure we identify is the lateral semicircular canal, isn't it? During cortical mastectomy, that's the identifier. And the posterior semicircular canal is further 2 mm medial to it. And superior semicircular canal, we have to go another 2 mm medial to it. So this is the surgeon's view. So first what we get is lateral semicircular canal, then what we get is posterior semicircular canal, and further medially we get is the superior semicircular canal. So we have to remember this staggering level. Coming to the important ducts in the temporal bone, point number 13, that is vestibular aqueduct. Okay, vestibular aqueduct usually posterior to the posterior semicircular canal, a thin duct, and this is again parallel to the long axis of the temporal bone and perpendicular to the internal artery meatus. Okay, remember that. Whereas cochlear aqueduct, this is a duct which connects from the basal turn of the cochlea, okay, starting of the basal turn of the cochlea to the posterior cranial fossa. This is perpendicular to the long axis of the temporal bone. Okay, where this is parallel and this is perpendicular. Okay, that is easy identifier. And basal turn of the cochlea we should be able to identify, and also round window niche which looks like an air bubble here. Okay, and this is the vestibular aqueduct, okay? This is parallel to the long arcs of the temporal bone and perpendicular to the internal artery meatus. This is the identifier. Cochlear aqueduct, okay? This is perpendicular to the long axis and parallel to the internal artery meatus. Internal artery meatus is not seen here because the cochlear aqueduct is inferior to the internal artery meatus. It runs inferior to the internal artery meatus. Another important structure we need to identify is subarcuate canal, very important. This is usually this subarcuate artery branch of labyrinthine artery runs and supplies the metatarsal systems. This runs under the arch of the superior semicircular canal. You can see two limbs of the superior semicircular canal. Under the arch it is running. Okay, here this is the superior semicircular canal, this is the subarcuate canal. Okay, and what is the surgical importance of this is whenever there is a fracture of the temporal bone, sometimes this subarcuate canal can mimic a fracture. Okay, so don't confuse with that. Coming to the great results, we remember that anteriorly this is the sagittal view. So this is where jugulo-keratico crest, keratico-jugular crest. Okay, this bone separates the internal carotid artery from the internal jugular vein and the jugular bulb. Okay, here this is the internal carotid artery and this is the jugular bulb, but two horns of the jugular bulb. Okay, jugular bulb has two parts. One is pars nervosa here medially and pars venosa laterally. Okay, that we need to remember. Okay, and if we look at axial section at the two levels here, this is axial section superiorly, how the internal carotid artery looks, like a tube. Okay, because the axial sections runs parallel to this part of internal carotid artery. Okay, whereas here at a lower level, this looks like a circle. That's we have to remember. Okay, internal carotid artery as it ascends up becomes genu and then the horizontal part of the internal carotid artery. Coming to the internal artery meatus, there is very easy mnemonic. This is the falciform crest and this is the Bill's bar. This is also known as transverse crest. Anterior superiorly we have what we have is 7 up, that is anterior superiorly we have the facial nerve and anterior inferiorly we have the coke down, that is the cochlear nerve. Posterior superiorly we have the vestibular nerve, superior vestibular nerve, and inferiorly we have inferior vestibular nerve. This is the arrangement we have to remember. Okay, and here you can see the horizontal crest. On a sagittal section you will be able to identify the horizontal crest and the vertical crest is this. Okay, on a sagittal section. On an axial section, this is the vertical crest. Anterior to it is the labyrinthine part of the facial nerve, first genu, and GSPN and horizontal part of the facial nerve. Okay, here again you can study. This is the on a coronal section. This is the transverse crest. Okay, superior to the transverse crest is the facial nerve, and inferiorly you can see the cochlear nerve entering into the cochlea here. Okay, that we should be able to identify. Some mnemonics, picture mnemonics I would like to remind you. See the tube and circles I told you, remember, whichever plane we are in, if it is parallel it looks like a tube, if it is perpendicular it looks like a circle, and another mnemonic, picture mnemonic is the snake eye appearance. Okay, as we go down, the superior semicircular and axial sections, two arches of the superior semicircular canals, they looks like a snake eye. That remember. Also superior semicircular canal, the arch, superior arch, which is perpendicular to the long arch of the temporal bone, may look like a sausage appearance. Two structures show sausage appearance. This is superior semicircular canal as well as the basal turn of the cochlear and axial section have a sausage appearance. And this is very important to plane. I told you a dramatic plane for that matter, that is where floor of the external canal is at the floor of the internal meatus at the roof of the external canal. Okay, at this level lot of things happen. One is cochlea, one is ossicles giving a typical ice cone appearance. At the same level we also have a cochlea, and this is cochlear aperture. We should be able to study the cochlear aperture dimensions, which indicates the thickness of the cochlear nerve, and also within the cochlear aperture you will be able to, the divisions you should be able to appreciate. At this level, this is artery-epitympanum. We also see horizontal part of the facial nerve, and this is vestibular and lateral semicircular canal, typical signet ring appearance, and the epitympanum and mastoid giving, through the auditors giving a hourglass appearance, and this is the coroner's plate. Okay, and this is the mastoid cortex, which we should be able to appreciate. And anteriorly here, anterior to the external canal, we see the zygomatic process also is pneumatized here. So all these structures we should be able to identify at this level. Okay, that's a very important. Another picture this thing I keep is, this is woodpecker appearance. Woodpecker appearance to study labyrinthine part and first genu of the facial nerve. You can see the vestibule, signet ring, the typical appearance, internal artery meatus, and this is the vertical crest. Okay, and here you can see anterior to the vertical crest or Bill's bar. You see this is the body of the woodpecker is formed by the interartery meatus, whereas neck is formed by the labyrinth part of the facial nerve. The head of the woodpecker formed by the first gene of the facial nerve, and hood of the facial nerve is the GSPN nerve, and the beak of the woodpecker is the horizontal part of the facial nerve. This one picture I keep it, and this is approach to the mainly for the cochlear implant surgeons. That is, how do we measure how much space we have in the facial recess? This is the facial recess, this is the extraordinary canal, posterior of the extraordinary canal, and this is the facial nerve, and between these 2 points is the facial recess. And this is the basal term of the cochlea, where we are going to introduce our electrode, and this is the round window niche where air bubble appearance is there. That's the round window niche. So this is the distance we need to measure for the cochlear implantation. And the cochlea, it gives a typical appearance of a mulberry tree appearance. That is another picture, this thing. And again, this is the division of the interlateral meatus. I have already told you. One singular nerve, this you need to remember, which accompanies the inferior vestibular nerve. Singular, this is the singular nerve, okay? It is inferior to the interlateral meatus here. Interlateral meatus is not seen. This is the lower part of the interlateral meatus, and this is the singular nerve, okay? This singular nerve. Now, some surgeons do perform singular neurectomy for uncontrolled BPPV. That's to identify the singular nerve is here, okay? That we need to identify. Ice cone appearance, I've already told you, and signet ring appearance, that is vestibule and the lateral semsecanal together. And this is swan appearance, that is when you're studying the coronal suctions, this is the lateral attic plate or scutum, and here you see this is the body of the swan is formed by the body of the swan is formed by the cochlea. Here, this is the basal term of the cochlea, and here we have the vestibule, that is neck of the swan, and the beak of the swan is formed by the lateral semsecanal, and the hood of the swans. There are hooded swans are also there. That is by superior semsecanal. Usually, you see the facial nerve under the beak of the swan, okay? And the neck of the swan is also formed by where the vestibule is here. This is the oval window, okay? Oval window, remember, neck of this thing, and that's where the stapes you should be able to observe on HRCT temporal bone. And also, if you want to study the round window, how it is seen on the round window, yeah, okay, round window in a coronal section, how it is seen is as inverted flask appearance here. This is the lateral semsecanal vestibule, this is the interartery meatus, and this round window in a coronal section looks like a inverted flask with lateral semsecanal being the handle of the flask, okay, that is another appearance. And subcochlear axial tract, this is for cochlear implant surgeons very important. This is a hypotympanic axial tract which runs below here, below the cochlea here. Cochlea is here, this is the round window niche, and there is a cell tract running here. Sometimes if they are not very careful, they may introduce the electrodes instead of the cochlea into this subcochlear axial tract. Identifying this is very important. This is below the cochlea, anteriorly we have the intraocular artery, posteriorly we have the jugular bulb, and this is subcochlear canal. That's the other thing we need to identify. Another mnemonic, picture mnemonic is hypoglossal canal. This hypoglossal canal, this bone looks like a eagle's head appearance. Under the beak of the eagle is the hypoglossal canal is there, that is in relation to a temporal bone we study, okay? You can see typical beak appearance here. Hypoglossal canal is an axial section seen here, okay? This is the hypoglossal canal. And subarachnoid canal, I told you already, subarachnoid canal. Here, this is the subarachnoid canal, this is the superior semsecanal canal. It runs between below the arch of the superior semsecanal canal to open into the mastoid. We should be, one more thing, how do we identify the lateral, the different semsecanals canals on a coronal suction? You look at this policeman appearance. The raised hand is superior semsecanal canal, and the extended hand is the lateral semsecanal canal, and posterior semsecanal canal is the legs. Okay, this is one mnemonic I keep myself this thing. And while studying the skull, also we need to remember some skull-based foramina. So I say this rose. Okay, this is this thing I keep mnemonic. So this is foramen rotundum. Okay, one this thing is there. One foramen which runs like a tube, which goes posterior to anterior direction. It runs. Then the foramen oval. Okay, then we have foramen spinosum next. Then the eustachian tube we have here lateral to the extrinsic canal. This is one foramen. Thank you very much for giving me an opportunity. This is a long lecture. I try to shorten it, cut short it. And this is our institute hospital, which has a state-of-the-art surgical skill lab in the basement, and we have an auditorium on the fourth floor. And starting from January 4th, 5th, every alternate week we have a course. Hands-on training course. We focus mainly hands-on training courses. That's what we believe. If you want to teach somebody, you should let them do something hands-on. So please keep track on our website, kenthospitals.com, so you can get to know about our courses. Do visit our center, be my guest, enjoy the hospitality. At least give an opportunity to return what I've enjoyed here in this thing, Sholapur. And I felt like I am a son-in-law, I was pampered like a son-in-law here. Thank you very much for that. Yeah.
Thank you, sir,
Thank
for
you.
the very...
And also, my heartfelt congratulations and heartfelt thanks to the team Sholapur, led by Dr. Prasad Kilk and the entire team. They've done a wonderful job. I think it's very difficult to emulate such an organization. Thank you very much, sir. Yeah.
Thank you, sir, for the very informative lecture. I would request the chairperson, Dr. Rajendra Pagare, sir, to felicitate Dr. N.B. Prahlad, sir. I would like to call upon stage Dr. Mrutyunjay Bilgi, sir, to felicitate the chairperson.